Welcome back, everyone. Before we dive into today's brand new content, let's honor the promise we made in episode 1. Those SHU and long answer questions you've all been waiting for. The first question was, a patient requires urgent pain relief but is vomiting and cannot swallow. List 2 appropriate routes with one drug, example each. The key insight here is simple. If the patient cannot swallow or is vomiting, you immediately eliminate the oral route. Full stop. Your first answer should be the rectal route, PR or parectal. Think of diazepam given rectally to children having febrile seizures. Why does this work? Because it avoids the GI tract almost entirely, bypasses about 50% of liver first-pass metabolism, and crucially, it works even when the patient is unconscious or actively vomiting. Your second answer is intravenous or IV. Think of morphine given for pain relief. This gives you 100% bioavailability, the fastest onset of any route, and completely bypasses the GI tract. In an emergency, this is your gold standard. Other acceptable answers include intramuscular. For example, ketorolac or morphine IM, sublingual for nitroglycerin, transdermal for sustained non-urgent relief, or inhalational analgesics in select settings. The golden rule here, vomiting or unconscious patient, you have to avoid oral route. Go for rectal, IV, sublingual, or transdermal. Our question 2 was like, explain why the oral route is not suitable for propranolol in some patients. What pharmacokinetic process is responsible? Well, here is the chain of events you need to walk the examiner through in your exam. A propranolol tablet is swallowed. It gets absorbed from the gut into the portal vein. It then passes directly through the liver before it can reach the systemic circulation. In the liver, CYP2D6 enzymes get to work, and they destroy most of it. We are talking about less than 10% actually surviving to reach systemic circulation. Oral bioavailability is only around 20% or 25%, and that figure is widely variable between patients. Why the variability? Well, we say that the genetics in these patients differ. CYP2D6 activity differs between people. Extensive metabolizers may break through 90% of the drug. This implies that there will be minimal clinical effect of this drug. Poor metabolizers accumulate the drug, and this predisposes them to toxicity risks. Same oral dose, completely different blood levels. This process is called first-pass metabolism or pre-systemic metabolism, and propranolol is the textbook example. Other drugs that suffer the same fate use the mnemonic known as have large pre-systemic metabolism, whereby have OH stands for hydrocortisone, large stands for lignocaine, propranolol, salbutamol, and morphine, plus nitrates and pethidine. Or you could use nitrates have large pre-systemic metabolism, whereby nitrates goes for nitrates, hydrocortisone goes for have, then lignocaine with large, pre for propranolol, salbutamol, morphine, and pethidine. The clinical solution, use IV propranolol in emergencies. 100% bioavailability in this case bypasses the liver completely. Or adjust the oral dose using plasma level monitoring. For our long answer question that asked you to compare all routes, by the way, it's important that you screenshot this table. It appears in every pharmacology exam. IV gives you 100% bioavailability and the fastest onset, under 1 minute, but once given, it cannot be recalled, and there is a risk of embolism with IV. We'll talk about that in detail at one point. Then sublingual gives about 75% bioavailability with a fast 2 to 5 minute onset. It completely avoids fast-pass metabolism, but you're limited to small doses. Oral is the safest and cheapest, but bioavailability varies between 25 and 75% because of fast-pass metabolism. Not suitable for vomiting patients. Then rectal avoids about 50% of fast pass metabolism. It has moderate onset, but absorption is erratic. Transdermal offers sustained release and avoids fast pass metabolism, but onset is measured in hours, not minutes. Think of fentanyl patch for chronic pain. Then inhalation gives fast onset and direct lung action with minimal systemic side effects, but technique matters. Think about salbutamol in this case. Now, before we go any further, I want you to think about this. A 60-kilogram patient takes a 30 milligrams oral morphine tablet. Her doctor gives the same drug intravenously, but at only 10 milligrams, one-third of the dose. Same drug, same patient, completely different doses, yet the same clinical effect. How is that possible? Think about it. Well, oral morphine has a bioavailability of only 30 to 40%. So out of that 30 milligram tablet, only about 9 to 12 milligrams actually reaches the bloodstream. The IV route, 100%. You understand? Like you remember we say that for the IV route, for it gives the bioavailability of 100%. So every milligram you inject goes directly into circulation. What's the answer? The answer to this lies in pharmacokinetics, and that is exactly what episode 2 is all about. Welcome to Bright Life Scientists. BLS, Illuminate, Educate, Inspire. This is episode 2, Pharmacokinetics Part 1, Absorption and Bioavailability. Let's get into it. By the end of this video, you'll be able to do 6 things. Define pharmacokinetics and distinguish it from pharmacodynamics. Explain the 4 phases of ADME with clinical relevance. Describe the mechanisms of drug absorption, including passive diffusion and the effect of pH. Explain fast-pass metabolism and its clinical consequences. Calculate and compare bioavailability across different routes. Apply all of this to clinical exam style, clinical scenarios. These are not just academic objectives, these are the exact things that come up in your pharmacology exams, your clinical reasoning, and most importantly, your patient care. Let's go. What is pharmacokinetics? Pharmacokinetics, or PK, is simply the study of what the body does to a drug. If pharmacodynamics asks what does the drug do to the body, think mechanism of action, receptor, binding, effects. Then pharmacokinetics asks the opposite. What does the body do to the drug? And the body does 4 things. We call them ADME, absorption, 4A. The drug enters the bloodstream from its site of administration, routes, passive transport, fast pass. All of this governs absorption. For distribution, which is D, once in the blood, the drug spreads into tissues and organs. How far it spreads depends on the volume of distribution, which is known as VD, and protein binding. Metabolism, which is M, the drug is chemically modified, mainly in the liver. Phase 1 and Phase 2 reactions. CYP enzymes, prodrugs, these can activate or inactivate the drug. For excretion, which is E, the drug or its metabolites leave the body, mainly via the kidney, but also through the bile, the lungs, and other routes. Critical clinical takeaway. Same dose does not equal to same effect in every patient. PK determines how much drug reaches the target, when it gets there, how long it stays, and how it lives. So understanding PK is understanding why patients respond differently to the same medication. Now let's talk about absorption and mechanisms. So what is absorption? Absorption is the movement of a drug from its site of administration into the systemic circulation. Notice that this does not apply to intravenous drugs. An intravenous drug is already in the blood. There is no absorption step here. So for every other route, the drug must cross biological membranes to get into the bloodstream. There are 4 mechanisms. 1, we have passive diffusion, which is the most common. The vast majority of drugs cross membranes this way. The drug moves down its concentration gradient. Here, there is no energy required. The key requirement here Lipid solubility. The drug must be in its unionized form. Then mechanism 2, we have facilitated diffusion, which is carrier mediated. Here a carrier protein helps the drug cross the membrane. Still it does this down the gradient. No ATP is needed, but the carrier can become saturated. Then mechanism 3, we have active transport, which is always against the gradient. The drug is moved against its concentration gradient, requires energy in form of ATP. Here it is also carrier mediated and the carriers can become saturated. The classic example of drugs that use this mechanism, we have levodopa and methyl dopa. Then the last mechanism, we have pinocytosis, which is engulfing. The cell membrane engulfs drug particles. This is only for very large molecules and it is very slow and limited. Example of drugs that use this mechanism, we have oral polio vaccine, OPV. For your exams, passive diffusion is the answer, unless the question specifically points toward a carrier-mediated mechanism. Now, let's talk about pH and ionization. The golden rule, only the unionized form of a drug is lipid-soluble and can cross membranes. The ionized form is water-soluble and gets trapped. Whether a drug is ionized or unionized depends on the pH of the surrounding medium and the drug's pKa, which is governed by the Henderson-Hasselbalch equation. I will talk about that in detail later. For weak acids, drugs like aspirin and warfarin, these are predominantly unionized in acidic environment. The stomach pH is around 1 to 3, that is basically acidic. So aspirin stays unionized there. This makes it lipid soluble and gets absorbed in the stomach. For weak bases, drugs like morphine and atropine, these are predominantly unionized in an alkaline environment. The small intestine, the pH is usually between 7 to 8. That is alkaline. So morphine becomes unionized there and gets absorbed in the small intestine. When pH equals to pKa, 50% of the drug is ionized and 50% is unionized. When the difference between pH and pKa is 1, 90% is ionized and 10% is unionized. When the difference of pH and pKa is 2, 99% is ionized and 1% is non-ionized. Clinical food for thought. If a patient takes aspirin with an antacid, the antacid raises gastric pH. Aspirin, a weak acid, becomes more ionized. This makes it less lipid soluble, which therefore reduces its absorption. And thus, this results into a reduced bioavailability. This is a real clinical interaction. Beyond pH and ionization, several other factors determine how well a drug is absorbed. Let me walk you through the 6 important ones. 1. Lipid solubility. Higher lipid solubility means the drug crosses membranes faster and achieves greater absorption. Fat-soluble drugs like diazepam absorb extremely well orally. Then we have degree of ionization. This is governed by pKa and pH. As we just discussed, only the unionized fraction is absorbed. Then we have molecular weight. Smaller molecules pass more easily. Very large molecules like heparin, insulin, these cannot be absorbed orally. This is why insulin must be injected. Then we have surface area. The small intestine has a surface area of approximately 200 meters squared. Thanks to villi and microvilli, this is the primary site of absorption for most drugs. Then we also have blood flow at the site. Rich blood supply rapidly removes absorbed drugs, maintaining the concentration gradient and driving further absorption. For example, intestine absorbs more drugs than the skin. Then we have food and GI motility. Well, food can delay gastric emptying. This slows absorption or enhance absorption of fat-soluble drugs. Diarrhea reduces contact time and therefore reduces absorption. Now we arrive at one of the most clinically important concepts in pharmacokinetics, which is first-pass metabolism, also called pre-systemic metabolism. Here is what happens. You swallow a tablet, the drug is absorbed from the GI tract into the portal vein, the blood vessel that drains directly into the liver. Before the drug can reach the systemic circulation, it must pass through the liver first. The liver, being the body's metabolic engine, gets to work with its CYP enzymes and destroys a significant portion of the drug before it ever gets to act. Liver disease reduces fast-pass metabolism, therefore the drug accumulates and bioavailability shoots up, and this predisposes an individual to risks of toxicity. Now let's talk about bioavailability, the concept itself and the formula. So what is bioavailability? Usually bioavailability is abbreviated as AF, which is the fraction of the administered drug that actually reaches the systemic circulation in its unchanged form. Bioavailability is the fraction of the administered drug that actually reaches the systemic circulation in its unchanged form. The formula of bioavailability is AF equals to AUC of a given root. AUC stands for area under the plasma concentration. So the formula is F equals to AUC of a given root divided by AUC of IV times 100%. So why do we always use IV as the denominator here? It is because IV gives 100% bioavailability. So it is the gold standard reference. Everything else, any other route, is compared to it. Three parameters matter on the plasma time curve. We have Cmax, which is the peak plasma concentration. Then we have the Tmax, which is the time it takes to peak. This time it takes to peak reflects the rate of absorption, and AUC, which reflects the extent of absorption. Remember, AUC is the area under plasma concentration. Then here there is an important table that shows the bioavailability of different routes. You can pause, take a screenshot, and read about it. It is a very important table, by the way. Sometimes they bring these options in MCQs where they ask you the estimated bioavailability of each route. Now, let's talk about distribution and volume of distribution. Once a drug is absorbed into the bloodstream, it distributes, spreading from blood into tissues. The extent of that distribution is described by the volume of distribution, which is denoted as VD. The formula of volume of distribution is dose divided by concentration, the initial plasma concentration. The dose is in milligrams and the initial plasma concentration is in milligrams per liter. VD, which is the volume of distribution, is a hypothetical volume. It does not correspond to any real anatomical space. It is the volume that would be needed to contain the entire drug dose at the plasma concentration observed. Low VD of less than 20 liter, this drug stays mostly in plasma. It is highly protein bound. For example, we have warfarin. Then those ones with moderate VD between 20 to 40 liter, this one distributes into body fluids. High VD of more than 50 liters, here the drug is sequestered in peripheral tissues and the plasma concentration is very low. Then we have what we call as plasma protein binding. Here only the free unbound drug is pharmacologically active. Those drugs that are highly plasma protein binding, they have low VD. They stay in plasma. So drug displacement usually happens when two highly plasma protein binding drugs compete for binding sites, and this results into them displacing each other. So this causes free drug rises and thus causes toxicity. Then in dialysis, we all know that dialysis removes drugs, but it only removes the drugs with a low volume of distribution and low plasma protein binding capacities. For example, salicylates. Drugs with high VD like digoxin and chloroquine cannot be dialyzed. By the way, chloroquine has a VD of 1,300 liters per kilogram. That's around 91,000 liters for an average person. We'll talk about this in details later. Now, let's talk about distribution barriers. So, you need to know that not every drug can reach every part of the body. Yeah, you need to know that. There are specialized biological barriers that prevent access to specific compartments. Here we have the blood-brain barrier, the triple B, BBB, placental barrier, blood-testis barrier. Now, let's talk about the blood-brain barrier. To cross this compartment, a drug must be lipid-soluble, it must be unionized, it must have a small molecular weight and not heavily protein bound. General anesthetics, sedatives, and levodopa cross. These are blood-brain barrier. Penicillin does not normally cross this blood-brain barrier, but in bacterial meningitis, the blood-brain barrier becomes inflamed, making it permeable. This is why high-dose penicillin can treat bacterial meningitis. For the placental barrier, it is less selective than the blood-brain barrier. Lipid-soluble, low-molecular and ionized drugs cross freely. Thalidomide crossed the placenta and caused the limb defects in thousands of babies. Warfarin, tetracyclines, aminoglycosides are teratogenic, so they must be avoided in pregnancy. Then we have heparin. It is large, polar, and it cannot cross. Hence, heparin is preferred in pregnancy. Then we also have the blood-testis barrier. It is clinically important in oncology. Some chemotherapy agents cannot penetrate this barrier, leading to the concept of testicular sanctuary in cancer treatment. Let's talk about metabolism. Metabolism, this primarily occurs in the liver, which transforms drugs to make them more water-soluble and easier to excrete. Metabolism happens in two phases. We have phase 1, which is non-synthetic. Phase 1 reactions add a functional group to the drug molecule. Reactions here in phase 1 include oxidation, reduction, and hydrolysis. The enzymes involved, we have CYP450 mainly. The products may be lipid-soluble or water-soluble. Phase 1 sometimes activates prodrugs. For prodrugs, actually, these are drugs that are in inactive form, then they have to be converted to active form. Codeine is converted to morphine by CYP2D6. So codeine is in its inactive form, otherwise it's a prodrug. So by this enzyme CYP2D6, it is converted to morphine. Then the phase 2, it is the synthetic conjugation. Remember I said for phase 1, it is non-synthetic, so phase 2 is synthetic conjugation. Phase 2 attaches a large water-soluble molecule to the drug. Processes involved here include glucuronidation, acetylation, methylation, sulfation. All phase 2 products are water-soluble, ready for excretion. Now let's talk about enzyme inducers. These enzyme inducers, they increase the metabolism of the drug, and this results into decreased drug effect. Take an example of rifampicin here, phenobarbital, phenytoin, griseofulvin, carbamazepine, St. John's wort. These are enzyme inducers. Then we have enzyme inhibitors. These ones, they decrease the metabolism of the drug and thus increase the toxicity of the drug. We have ketoconazole here, cimetidine, erythromycin, metronidazole, valproate, and ciprofloxacillin, plus grapefruit juice. Now, let's talk about CYP450 enzymes. This table is very, very important. If possible, just screenshot it. It appears virtually on every pharmacology exam. Usually they ask about these enzymes and you have to answer them. So these CYP450 enzymes, they have categories. We have enzyme CYP3A4. It is actually very important. It metabolizes 33% of all drugs. Talk of statins, cyclosporine, tacrolimus. The key inducers here in CYP3A4, we have rifampicin and St. John's wort. And then the key inhibitor, we have erythromycin, ketoconazole, and grapefruit juice. We said for the inducers, these ones, they increase their metabolism, and thus they decrease the effect of the drug in the body. And for the inhibitors, for them, they decrease the metabolism of that given drug. Otherwise, the liver will not break this drug as much, so it will leave much of the concentration of this drug in the body. What this does, it increases the toxicity of that given drug. So in CYP3A4, we said it metabolizes 33% of all drugs, the statins, cyclosporins, tacrolimus. But the main inducers here, we have rifampicin, St. John's wort. Then the key inhibitors here, we have erythromycin, ketoconazole, grapefruit juice. Please, if there's any one thing you're going to master in this whole video, I think this table is quite important because they like bringing these ones in MCQs. Then we have CYP2D6 enzyme. Here it metabolizes most of the antidepressants, beta blockers, antiarrhythmics, polymorphic. For it actually has no known inducer for CYP2D6. But the key inhibitors for this CYP2D6, we have quinidine and paroxetine. Then we have CYP2C9. For it metabolizes phenytoin, warfarin, tolbutamide. The key inducer here, we have rifampicin, and key inhibitors, we have erythromycin and cimetidine. And we have CYP1A2. It metabolizes theophylline. We have warfarin, and smoking induces it sometimes. So what are the inducers of CYP1A2? We have smoking and rifampicin. You see that rifampicin almost occurs in every enzyme here as an inducer, apart from CYP2D6. You understand? If there's one thing you have to take also from this one, you take that one. At least you have rifampicin. Then for the inhibitor of CYP1A2, we have ciprofloxacin. Very important. For grapefruit juice, it contains furanocoumarins. These irreversibly inhibit CYP3A4 in the gut wall for 24 to 72 hours. One glass can raise statin and cyclosporine levels to dangerous levels. So, if ever you have a patient who's taking any of these drugs, never let them take grapefruit juice with their statins. It will cause toxicity. Excretion is the final step. Now, let's talk about how these drugs and their metabolites leave the body. Now, there are three important sites, actually, through which these drugs are excreted. We have the renal excretion. And in the renal excretion, we have three important steps that are involved. We have glomerular filtration. Here, only free and unbound drug is filtered. Then we have the tubular secretion, and we have also tubular reabsorption. In tubular reabsorption, unionized lipid-soluble drugs get reabsorbed. We also have phosphodiuresis. Here, alkalinizing urine with sodium bicarbonate traps acidic drugs like aspirin and phenobarbital. These become ionized in alkaline urine, so they cannot be reabsorbed and they get excreted. This is the treatment for aspirin overdose. Acidifying urine traps basic drugs like amphetamine. Then we have biliary or fecal excretion. This is the secondary route. Large molecules that are secreted into bile, they are taken to the intestines, and from there they are excreted as feces. Some of these drugs actually get reabsorbed from the intestine into the portal circulation, enterohepatic circulation, extending the half-life of these drugs. Classic examples of such drugs include rifampicin, tetracyclines, or estrogen, but cholestyramine interrupts enterohepatic circulation. This is used therapeutically. Then we also have pulmonary excretion. Gases are excreted in this way. We have volatile anesthetics like halothane and isoflurane are eliminated via the lungs. The breath alcohol test exploits the same principle of pulmonary excretion. Exhaled alcohol reflects blood alcohol level. So in excretion, we have the renal excretion, we have the biliary or fecal excretion, and also we have the pulmonary excretion. Now here we have some MCQs for you. There are 3 MCQs. Just pause the video and answer them in the comment section. The answers will be revealed anyway in the video, but try yourself. Yeah. Now, going back to our opening question, do you remember our opening question? Why does oral morphine need 3 times the IV dose to achieve the same effect? Now, let's answer it now properly using everything we have covered in this video and from the start. One of the reasons we have fast-pass metabolism, which destroys most of the oral dose. So, morphine undergoes extensive hepatic fast-pass via the CYP enzymes. Only about 30% of the oral dose survives to reach the systemic circulation. But IV morphine bypasses the liver entirely. So for the IV morphine, it reaches there when it is 100%, its bioavailability. Now, the other reason is bioavailability differs by route. Oral morphine, its bioavailability is approximately equals to 25 to 35%. But for IV morphine, the bioavailability is around, it's actually 100%. So 30 milligrams of oral morphine is roughly equivalent to 10 milligrams IV. Same clinical effect, completely different prescriptions. Then also we have ADME, which explains everything. Absorption, the given route, the distribution, the volume of distribution and protein binding capacity. And then we also have metabolism, CYP2D6 and fast pass. Then we also have excretion. These all differ between oral and IV administration. This is the fundamental reason why the same dose does not equal the same effect. Now for our MCQs, the answers are also here. Answer for our number one MCQ was 30%, which indicates that the bioavailability is the amount reaching the saturation divided by dose given. So if the amount reaching the saturation is 30 and the dose given is 100%, so you will be left with it will be equal to 30%. The remaining 70% was lost to fast pass, metabolism, and incomplete absorption. The formula of bioavailability, we said it is equal to F equals to AUC of a given route. But now, in this case, the given route is oral divided by AUC of IV, which is the gold reference, gold standard actually, multiplied by 100%. For number 2, the answer is passive diffusion, and number 3, the answer is the drug is sequestered in tissue, C. Now, test your deeper knowledge with these SHUs. You can pause the video, go and read about them, and drop your answer in the comment section. But of course, as usual, in our next episode, we'll start with these answers to these SHU. We have SHU1, a patient with chronic kidney disease takes a drug that is 90% renally excreted. Explain what happens to the plasma drug concentration over time and what dose adjustment is required. You read all of them and you answer them as well. Just drop the answers in the comment section. Now, fact frog time. These are facts that will make your friend think you're a walking pharmacology encyclopedia. Fun fact 1. Chloroquine has the highest VD of any drug, that is around 1,300 liters per kilogram. For an average person with 70 kgs, that is around 91,000 liters. Where is all that chloroquine? Well, it is massively concentrated in tissues, especially melanin-containing cells, including the retina. This is why chloroquine causes retinotoxicity with long-term use. It literally accumulates in the eye, and it cannot be removed by dialysis. There is virtually none left in the blood to filter out. Ask your classmates what's chloroquine's VD, then watch their faces. And fun fact 2. Grapefruit juice is a drug interaction in a glass. It contains compounds called furanocoumarins, specifically bergamotine, that irreversibly inhibits CYP3A4 in the gut, not temporarily but irreversibly. So one glass can inhibit CYP3A4 for about 24 to 72 hours. That's about 1 to 3 days. During that window, plasma levels of simvastatin, cyclosporin, felodipamine can rise to dangerous levels, with the risk of rhabdomyolysis from statins and nephrotoxicity from cyclosporins. So FDA requires grapefruit juice warnings on multiple drug labels because of this. Now, let me give you the BLS memory trick for pharmacokinetics. We have a mnemonic here for pharmacokinetics. We said a drunk man eats, whereby A stands for absorption, D stands for distribution, M stands for metabolism, and E is for excretion. Now, this is an exam tip. For any pharmacokinetics question, work through ADME systematically. It identifies the problems, it identifies the solution all the time. So, these are just summaries. You can just pause the video and you read through. I think for today, that is what wraps up our episode 2. We started with the question, why does oral morphine need 3 times the IV dose? And we have now answered it completely from first principles. You now understand absorption, distribution, metabolism, excretion, bioavailability, the CYP enzyme system, the distribution barriers, pH and ionization, volume of distribution, renal excretion. That is a full pharmacokinetics foundation, and it took us 1 video. Well, before you leave, hit subscribe for episode 3. If you found this video helpful in any way, please kindly like, comment, and hit the subscribe button. It will really help us grow our channel. and probably reach a given target that we need, such that we can be able to make these videos in a live format, whereby at least I'll be able to be writing on board. For now, we don't have as much of the stuffs we need, but along the way, we'll be able to make some good content for you that will be really helpful to the next generation of medics. For now, kindly hit the subscribe, like, and comment. Drop your SHU and long answer questions in the comments below. We read every single one, and the best answers get featured in episode 3. Share this video with a fellow student. If it helped you, it will definitely help them. This has been Bright Life Scientists. Illuminate, educate, inspire. See you in episode 3.